Right. So good morning, everybody. Welcome to what will be a lively discussion about the connection between health and housing and some of both the opportunities and challenges. We very much appreciate you taking time to listen in today. And we think that this will add some content, information, and perspective that can be very valuable for everybody that's in the policy arena. We're very fortunate today to have an incredible panel of experts from both the health and housing side of the equation to really talk about the history and the relationship between health and housing and the role housing plays in health and what some of the opportunities are to connect the two. And I think the wealth of knowledge and experience and perspective that you hear today is going to be very unique and something that we'll all be able to learn from. Let me introduce myself. My name is Steve Pontel. I'm the President and CEO of National Community Renaissance. We're honored to be the host of today's conversation. We are a nonprofit affordable housing developer and property manager, headquartered in California and also in Texas and Florida. And we're excited to continue to push the envelope on thinking of new ways to be able to solve the housing crisis, which is ultimately our goal. Not only do we create amazing facilities, but through our Hope Through Housing Foundation, we pay a lot of attention to services for our residents. We've been engaged in the health and housing conversation for about the last 8 years and have continued to build very strong partnerships, including with some of the panel members that we have here today. We partnered with Common Spirit, as is known nationally, Dignity here in California, for a significant development we have underway in the city of San Bernardino. And we're able to use Dignity's resources, part of the development stack for that property. We've also partnered with the Inland Empire Health Plan, which is one of the Medicare, Medicaid plans delivering services. And so we're excited to continue to pursue this conversation, to continue to learn from it and see what we can do to make changes. We're very fortunate that Congress member Roybal Allard got language in the HHS bill last year, asking HHS to study the relationship of housing, specifically targeting the homeless population and the impact on the costs of healthcare as a result of that. And so we're very fortunate to have partners in Congress and in the administration that are continuing to pursue these ideas. Let me just very quickly introduce our panel members, and then I'm going to ask each panel member to give their opening comments. But just to give you an idea of the wealth of experience that you have, it gives me great pleasure to introduce Dr. Tony Iton. Tony is the Senior Vice President of the California Endowment. The California Endowment is the largest health foundation in the West. Tony is the person responsible for implementing the place-based strategies of the California Endowment for the last decade. And I will say that the California Endowment's mission is a healthier California, so I can say Tony's responsible for the health of all Californians. And so, but a strong advocate, not only is he an MD, but a doctor of public health and a lawyer. And so he brings a lot of perspective to this conversation. Thank you, Dr. Iton, for participating today. And then in a minute, John Backus is going to be joining us. John is the Executive Director of LA Care. He actually had an appointment this morning, so he's running a bit late. But LA Care is the largest Medicare, Medicaid health plan in the country, with over 2 million lives within their plan, and is very interested in the social determinants of health and has implemented significant changes, especially targeting vulnerable populations such as the former foster youth and those that were formerly incarcerated. Pablo Bravo, as I mentioned before, is with Common Spirit. Pablo is responsible for not only some of the social impact initiatives of Common Spirit, but is responsible for their housing initiatives. And Common Spirit has invested significantly into housing as a healthcare system. And I think Pablo is one of the pioneers in looking at how to tie those two interests together. Betsy Crimmins is social determinant of health strategist, specifically has launched Trestle Health and Housing, LLC, which is specifically focusing on, how do we value and gain the benefits of service infused housing in building the cost of healthcare curve. And what are those services? What are those relationships? And how can we make that link occur? Betsy has, been pursuing these initiatives for a long time and brings a lot to the table. And then Scott Olsen. Scott is our advocate in DC. He is a very experienced DC advocate, having been the senior staff person on the housing for former Congressman Barney Frank, and has been a leader in housing initiatives, housing legislation, and has been championing on our behalf the conversation in the DC area about this relationship between health and housing. And so it gives me great place. We're going to start out with Dr. Eiton to kind of share some of what he's learned and observed about the relationship between housing and health. Dr. Eiton.
Thanks, Steve. And it's a real pleasure to be here. I'm going to try to provide a little bit of context for health and housing. I could spend a full hour describing the numerous studies that show significant linkages between health and housing as a key social determinant of health. But instead, I'm going to try to frame it out for you so that we have a context in which to speak, and some of my fellow panelists will describe some of the details in the programs and strategies that they've undertaken. But I used to run the Alameda County Public Health Department. For those of you who don't know where Alameda County is, it's the East Bay of San Francisco, includes the cities of Oakland and Berkeley. It's got about 1.5 million people. And early in our efforts there to try to understand how some of these social determinants were manifesting themselves, we decided we would study about 500,000 death certificates across a number of years in Alameda County and try to understand whether we could ascertain patterns of death when we mapped those death certificates across the county at the neighborhood level. And what we found after studying hundreds of thousands of death certificates were that these obvious patterns begin to emerge. And it led us to the observation that in the United States, when it comes to your health, your zip code matters more than your genetic code. And in essence, what we were able to do was to predict how long somebody would live based on just one factor, their address. And when you do that, you can make these guesses and you are right much more often than you're wrong. And that's not because we're smart, it's because these patterns are so rigidly manifest across the United States that they actually are now predictive. It shouldn't be that way. This is the product of the cumulative and synergistic legacy of racial and economic segregation. Let me repeat that. This is the product of the cumulative and synergistic legacy of racial and economic segregation, period. In other words, a layered constellation of laws, policies, institutional practices, and behaviors have created and reinforced these very predictable patterns. These patterns are now so rigid that they drive US life expectancy patterns. And these observations have been replicated over and over again across multiple cities in the United States. So to contextualize this for you, I want to sort of organize health and housing into 4 basic domains. The first one is neighborhood conditions, which I've alluded to in terms of these patterns. The second is unsafe or poor quality housing, housing that makes you sick. The third is housing instability, the fear of homelessness, the fear of essentially being evicted. And the fourth is the affordability of housing. And Steve and National Core and many of the panelists have long track records in trying to address that issue. On the neighborhood issue, the most important thing to think about is that neighborhoods shape health status by conferring access to health protective amenities. In low-income neighborhoods, there is a paucity of health protective amenities. So low-income neighborhoods lack parks, They lack full service grocery stores. They lack adequate transportation, meaningful employment opportunities, and quality housing stock. The neighborhoods also shape access to noxious sources of pollution like freeways or other point sources of pollution, as well as concentrations of fast food, liquor stores. In many communities in the United States, neighborhoods are aggressively policed, sometimes with military-style tactics. There's inadequate infrastructure, lacking sidewalks or other pedestrian amenities, and in some cases, sewage and potable water infrastructure is decaying and hazardous, in the case of Flint, Michigan, and other parts of the southeastern United States. The second domain is really the poor quality housing itself. It can have direct impacts, particularly on young children with lead poisoning, asthma, allergy exacerbations, exposure to secondhand smoke, pest infestation. The ongoing COVID epidemic has dramatically revealed the health consequences of crowded housing, which can facilitate the spread of communicable disease, including tuberculosis and other respiratory pathogens like COVID-19. It can also exacerbate emotional stress and put children at risk of sexual assault. Housing, a third domain is housing instability. Housing also shapes health through the psychological and emotional impact of instability and the fear of homelessness. Substantial health research reveals the health consequences of homelessness, including increased emergency room use, increased acute mental health care needs, elevated healthcare cost and utilization. Instability and the fear of eviction, frequent moving, couch surfing have profound and well-documented mental health consequences, particularly for children. And then finally, housing affordability, which you'll hear a lot more about from my fellow panelists, makes families dedicate an ever-increasing share of their income to pay for housing, which detracts from their ability to save, to purchase healthy food, to acquire necessary health care, and to invest in extracurricular activities for their children, for example. Understanding how all of this affects health is made clearer by understanding how all four of these domains feed into a final common pathway. Probably the easiest way to understand this is that neighborhoods, housing instability, poor quality housing, and unaffordability all act on the human body in the same way. The concept is referred to as allostatic load, or a simpler way of referring to it is chronic stress. Chronic stress drives up the body's secretion of cortisol, a stress hormone. And when it's chronically elevated, cortisol causes cardiovascular disease, metabolic changes, including facilitating type 2 diabetes. It enhances inflammation and turns down your immune system, so you have a much higher level of inflammation in your body, and you're more prone to get sick through viruses like COVID-19. And it causes changes in brain structure and brain chemistry. It even causes changes in genetic expression, and some of these genetic expression changes can be passed on in utero to the next generation. So cortisol has powerful impacts on human physiology, and chronic cortisol secretion caused by chronic stress driven by policy changes human physiology. So social determinants is really a misnomer, the concept of social determinants of health. Housing, education, access to healthcare, living wage, transportation, etc., are really policy determined influences on health. As such, these should more accurately refer to as political determinants of health. The drivers of these health inequities are man-made, and as such can be unmade through policy. We need to begin thinking of housing as a right and not a privilege of wealth. Shifting to a rights framework for shaping housing policy will go a long way towards reversing the inhumane homelessness crisis and reduce chronic stress in millions of Americans, thereby enhancing health status and increasing life expectancy. I now yield to my colleagues on the panel.
Thank you, Tony. That was a very helpful framing of obviously the connectivity of the issues is one of the things that I think is most difficult, especially in a political governmental environment where the silos are tall and the walls are thick and the issues are very technical. And so it's rational that, you know, the health people don't have time to talk to the transportation people, and the transportation people don't have time to talk to the education people, and the education people don't have time to talk to the housing people, because all of those are full-time jobs. So until we can figure out a way to think about it as a system and bring those together, I think some of these challenges will continue to struggle with. But great, thank you, sir. Since John is in his car right now, I'm going to let him listen to Pablo speak next, John, and we'll kind of let you get acclimated a little bit.
Okay, thank you.
Drive carefully, please. And so it gives me great pleasure to introduce our partner, Pablo Bravo, with Common Spirit. Pablo, can you share about kind of Common Spirit's view of this relationship?
Sure. It's tough following up Tony, but I think Tony, did the framework quite well. You know, he mentioned the zip codes. He mentioned the fact what some of these instabilities create, the stressors in our bodies that break down our systems, and therefore ends up being in some of our facilities. So before I start, I just want to share that Common Spirit Health is a healthcare provider. We're in 21 states. We have over 1,000 care sites across the country. My role within the organization is to oversee our community health programs, and that includes efforts to do capacity building, advocacy, through giving grants and investments. Our facilities, or through community health, we see housing is really a key, not only to address some of the issues, upstream issues in our communities, being, that we serve, but also where we see them at the facility level. I mean, when we screen individuals for housing insecurities, how do we address that? When we have homeless individuals coming to our emergency departments, to be able to just have a warm place to hang out for a little while and get a decent meal. So how do we address these issues? So Common Spirit several years ago established what we know as community investment program. This is a program where we use our own assets to be able to invest in different areas of the addressing the social determinants of health, whether it's housing, food, environmental, arts and education, job creation, et cetera. One of the major areas that we focus is really housing. 40% of our investments are allocated towards housing. One of our partners, again, is Steve, and a great project in San Bernardino. But from a hospital perspective, we look at housing with a continuum. So we invest in respite. We invest in scattered housing. We invest in supportive housing. And then from the community perspective, more upstream, we invest in neighborhood stabilization. We invest in housing developers who are focusing on not only on home ownership as a way to build assets on individuals, but also on the affordable rental housing. We look at partners not just as the developers of housing, but as a neighborhood developer, because it's not just about warehousing individuals. It's really how to develop an environment that is going to be safe. It's going to be environmentally healthy, and it provides a good place for individuals to live and grow and in a way that it's not going to impact their health. So our focus is Longwood. Why are we doing this? Well, I think Tony really addressed it. It's been written up over and over and over again that housing has a humongous impact on the health of individuals. And as a healthcare provider, I think that it's our responsibility to take a look at both from upstream and from our facility perspective.
Thank you, Pablo, and we appreciate your partnership and your leadership in this area. Betsy, I'm gonna go to you next. If you can kind of talk about the journey you've been on and the lessons you've learned of trying to put trestle in place and trying to, tie together the health services within stabilized housing. Betsy.
First, I'd start out by saying I would listen to Tony talk about this, not just for an hour, but for a whole day. I think he really did put everything in context. So my perspective comes primarily from working for most of my career as a legal services attorney in Boston, excuse me, and going into affordable housing regularly to deliver services for my clients. And there's no doubt in my mind, and I've known this for years, that affordable housing is the most important social determinant of health. And I'm still going to use that term, although I do agree with Tony that it is a political term, and I actually think it means that you're poor. So my journey with Trestle started about 3 years ago. I partnered with a really innovative healthcare executive named Bill Mulcahy, and really our model is premised on the idea that the healthcare world or the healthcare system and the affordable housing system are complicated, fragmented, and siloed. And as Steve just said, the silos are very high. And that is especially true for people who are trying to access the systems. So our model is really to serve as a bridge, a trestle bridge, if you will, to focus on residents. So it's a resident-centric model. What does a resident need and want, and how can we bring those services to them in the place they're most likely to accept it, which is their home? And this model recognizes that the healthcare system alone cannot begin to address the entrenched inequities that Tony discussed and that absolutely exist in, unfortunately, many zip codes across the country. We really need to bring all systems working together. And Trestle's role is really, we see our role as an integrator. So coordinating on behalf of the resident, not on behalf of Centene or Blue Cross or even a hospital system, but on behalf of the resident, what they need. So when you think about it, in affordable housing, we have many of our most vulnerable members, many with complex chronic illnesses, which can be very costly, all under one roof. So there's an opportunity right there. And that place is where many low-income people are most likely to accept help. They have trust relationships with housing staff. And I could tell you just from my 30 years of working with my clients that trust is not easily given. I have gone to people's homes multiple times after they've invited me to bring something important, to try to get somebody back on Medicaid or a SNAP application, and I can't get the door open because they don't know me and they don't trust me. And the first thing I always do is run downstairs and get the resident service coordinator. And he or she has worked in that building for 3 years, 5 years, 25 years, and they'll get the door open. So that trust and access to that resident is crucially important for the healthcare system sort of writ large to be able to engage a population that can be very difficult to engage with. Affordable housing also provides, I think, a really unique opportunity with the in-place capabilities to deliver services in innovative ways. So right before COVID started, we began a small pilot with an affordable housing in Newark, New Jersey. And the housing staff initially told us that one of the big problems for their senior elderly residents was people didn't have primary care providers. When we began meeting with the residents, they confirmed this. They also confirmed that when they didn't feel good or something happened, they would just go across the street to the emergency department at the local hospital, which is a really inefficient and incredibly costly way to get care. And it's not preventative. So the in-place capabilities that affordable housing provides allows us to look at people's health and social issues a lot further upstream. And while I typically don't like that word, I think it fits in this situation. So instead of reacting to health problems, which our healthcare system is usually doing, somebody is sick, they go to the doctor, but somebody's not getting preventative screenings to avoid getting sick in the first place. An example of that is through the Affordable Care Act, CMS now pays for whole host of screenings for Medicare beneficiaries. And the uptake on that across the country is fairly low. It's in the 20%. But for low-income populations, and especially low-income populations of color, the uptake is less than 10%. And those screenings, an annual wellness visit, chronic care management, are really the gateway to prevention. Why is that not being done floor by floor in every senior housing building across the country? That's, so our healthcare costs in this country are staggering. They're about to approach $4 trillion a year. And that's for relatively poor health outcomes, and especially for low-income populations. So how can we get our hands around, or our arms around, this unsustainable trend and really start to bend the cost curve while providing better health outcomes and better quality of life for some of our most vulnerable citizens? And I think one way to do it is obviously the trestle model, but we need so much more affordable housing in this country. So we need funding, lots of funding for affordable housing, and funding for housers like National Core that do incredible, critically important work for some of our most vulnerable citizens. So thank you.
Thank you, Betsy. The connection between once somebody has a stable living environment to then be able to have access to just thinking about the future, and it goes a long way. All right, John, I hope you're somewhat stationary. But if so, as I introduced John earlier before he got on board, you're muted still right now. But John is the executive director of LA Care, the largest public health plan in the country, with close to 2.5 million lives under his care. So John, maybe share a little bit about your observation and thoughts about the connection between health and housing and some of the stuff that you're trying to move forward.
Well, thank you, Steve. And I do want to tag on to Betsy's comment, and apparently Tony's. I do find the term social determinants of health grating. I like to refer to them as barriers to getting the right care in the right place at the right time. As you noted, we have a huge population of Medicaid beneficiaries enrolled here in Los Angeles County, the only county we operate in. At any given moment, 40 to 50,000 of our members are homeless. As a result of the Affordable Care Act and an outreach to get people on the street into healthcare so they'd have coverage, we now have this situation. Our biggest issue is that people say, well, if you could only pay for housing out of Medicaid, well, that would be great, except there isn't enough money in Medicaid to meet the kind of money that Betsy was referring to. We have done a bunch of innovative programs, paying for it out of our reserves for things like recuperative care. So when we have a member who is being discharged from an acute care setting, we will pay to put them in a recuperative care setting for 90 days. And during that 90 days, we work with a broad-based coalition of community-based organizations to find permanent supportive housing for that person so we don't discharge them back to the street. That program has limited capability of solving the problem, but it's a step in the right direction. We've also used some of our reserve money, $20 million over a 5-year period, that has provided permanent supportive housing for about 270 individuals and families. The other issue around food insecurity is huge, and we have since COVID been running food pantries at our community resource centers, and whenever we have one, the line of people there's still a line after we've given away all the food. So we know that your social determinants of health are barriers to care, and what we would like to see is more integration of the social services we as a nation are already paying for to be integrated with the care management that we're doing for our most highly vulnerable members. As I've mentioned, there is not enough money in Medicaid to solve the problem by starting to pay for food, even though it may bring a benefit later, or pay for housing that will bring a benefit later in reduced health costs. Medicaid is the lowest level of reimbursement. Medicare is more generous, and we cannot match what commercial insurers pay the providers in our networks. So we're looking for ways to tap into the money that's already being spent. And let me give you an easy example. All of our members are probably eligible for food stamps, yet they have to go to a separate agency, apply for the food stamps, give them all the same information we already have about them. They have to be recertified every 6 months by that agency, just as they have to be recertified annually by Medicaid. Why can't we, as the Medicaid managed care plan, who are screening everyone for social determinants, say Mrs. Smith needs food stamps. We already have all of her data. Why can't we be the agent that delivers that card to her, avoiding the administrative cost and deterrence to Mrs. Smith to have to go to yet another agency, give them all the same information all over again so they can get this very critical benefit. So we're constantly looking for ways that we can integrate social services into care planning for our vulnerable members, and they're all vulnerable. Remember, the Medicaid population was the most infected, hospitalized, and had the most deaths of people during COVID because they represent that cohort that had the least ability to protect themselves. I'll stop there, Steve.
Thank you, John. By the way, if people have questions, please drop them in the Q&A box, and we'll do our best to navigate through that. So now it gives me pleasure to introduce Scott Olsen, and Scott's going to lay out, from a DC perspective, his thoughts on, maybe some next steps. So with that, Mr. Olsen.
Good morning. I just lost something. There we go. Thanks, Steve. Thanks for the opportunity to participate in this great panel. My name is Scott Olsen, and I work as a consultant for National Corps. For 15 years, I was the top Democratic housing policy staffer on the House Financial Services Committee, working for Barney Frank until 2011. And I can't emphasize enough the problems and challenges of these separate silos, separate program silos in Washington. One, in Congress, we have separate congressional committees that deal with housing and healthcare issues. We have different federal agencies, HUD on the one hand and HHS on the other, and we have different programs. And these silos have been a particular problem and disincentive for housing investment, because federal housing programs serve millions of our most valuable families. But for example, instead of funding supportive services for these families in the appropriate federal programs like education and HHS, the limited direct resources we have for supportive services for families in federally assisted housing comes out of the HUD appropriations, in effect, stealing money from limited HUD funds that are desperately needed to pay for vouchers or housing construction. When John Backus with LA Care invests in housing, they get the financial cost savings on the healthcare savings side because it's a closed system. But HUD programs don't get any such benefit. They get no budget or appropriations credit for housing impacts by providing housing and in the process reducing federal healthcare costs or other federal expenditures. So National Corps has been a strong proponent of finding a way to make housing homeless and other vulnerable families and individuals, particularly those that are high-cost Medicaid healthcare users, to make that a priority and to come up with a reliable, scalable funding source. This would be a win-win-win, 3 wins, and a great investment for taxpayers. Because number one, we would house homeless persons. Number two, we would improve healthcare outcomes. And 3, we would reduce Medicaid and possibly Medicare expenses, at least for the seniors, for those that are homeless or other high-risk individuals that routinely use the emergency room as their primary healthcare source. So as I think Steve mentioned, we were thrilled last year by the leadership of Representative Roybal Allard, who secured report language in the Labor HHS Committee report that highlighted this issue and specifically called on HHS to explore more use of work in this area. An historical note: for decades, we've had a sensible policy of having Medicaid waivers for community-based care for seniors as a less expensive and preferable way or option than living in a nursing home. In recent years, we've seen Medicare waivers for supportive services in conjunction with housing. But I truly believe that based on my years of decades of congressional experience in housing, the next great frontier in housing and healthcare policy is to provide more integration through some way, whether it's federal funding through Medicaid or some other reliable source, or Medicaid rate waivers or whatever, to provide housing, provide rent to house homeless persons that are targeted to those with excessive Medicaid expenses in federally assisted housing units. So there are a number of ways to do this that federal policymakers can look at. But the first step, I think, is reaching consensus that this makes sense. And so I hope this webinar is useful in debating this issue. And with that, let me turn things back over to Steve for a more general discussion and for questions.
Thank you, Scott. A couple of thoughts that we're starting to get some questions in. Tony, let me ask you first, with regard to the data that you may be aware of between the health benefits of stable housing. And just a real quick context, I know when LA County made a commitment to produce 10,000 housing units for the most chronically homeless, their net savings per year was north of $30,000 per person. The cost of housing versus the cost of the services being demanded by by people when they were unhoused. But within LA County, they were able to aggregate the total costs of the sanitation costs and the law enforcement costs and in addition to the health costs, and so once again, as Scott indicated, when you add up all of those costs, which are usually allocated separately, you can really see the benefit. But the challenge we have is usually we can't accumulate those benefits across all of the areas that are impacted. But Tony, your thoughts on data that's available that demonstrates the health benefit, the savings and health cost as a benefit of housing.
Yeah, well, Steve, you did a nice job summarizing some of the clear benefits, the savings benefits of housing. I think that one of the challenges is the so-called wrong pocket problem, which one of our panelists did allude to, and that is that investments that reduce healthcare costs generally don't accrue to the investor. They accrue to a downstream participant in that system, the healthcare system, or what have you. And one of the reasons that I think philanthropy has been interested in looking at so-called social impact bonds is to essentially close that loop so that investors can benefit from the savings that are realized from their investments. The challenge obviously there is that government is not really configured to promote savings. And so you have kind of different cultures, an investor culture and sort of a government culture, and trying to sort of integrate those two things has proven to be quite challenging. But there's still some promising models out there that are looking to essentially solve this so-called wrong pocket problem and to essentially allow for investors, whomever they may be. They could be Wall Street investors, they could be philanthropic investors, they could even be government investors, that when they make those investments and take the risk of providing the social services that actually benefits, the housing, the social services, the variety of different types of proven strategies to reduce healthcare costs, when they take those risks, that they can actually realize the benefits. I want to make one other point, particularly for the congressional staffers that may be on this webinar. If you have a chance, get your hands on this little book called The American Healthcare Paradox by Elizabeth Bradley and Lauren Taylor. And what they show is that the countries that invest more heavily in social benefits and services, typically at a ratio of about $2 on social benefits and services, including housing benefits and the like, $2 for every $1 on medical care, tend to have the best health outcomes. in the United States, we spend about 55 cents on social services and benefits for every dollar on healthcare. And we talk about ourselves as being the big spenders. We're the big spenders on healthcare, on medical costs, but we're not the big spenders on social services. And when you add those two up, we're actually kind of roughly in the middle of the pack of other developed countries across the world. So, Betsy was making the point about the $4 trillion worth of expenditures. The larger story is that that's only part of our expenditure. Our problem is that we kind of have the accent on the wrong syllable, if you will. We're spending much more heavily on medical care when we could be investing more strategically in things like housing and social benefits, bringing down the downstream costs of healthcare. So read the book, The American Healthcare Paradox. It's a short book. It started as an op-ed in the New York Times. It's been replicated by RAND. So we know that this is very solid data that shows that if we want to improve health, we have to invest in social benefits and services, of which housing is probably one of the most important variables.
Yeah, thank you, Tony. Pablo, how does Common Spirit measure success within the initiatives that you're taking?
There's a couple of different ways. The success from a facility perspective is when a homeless individual comes into the hospital, has a place to transition to, whether it's a respite or a scattered housing or supported housing. So that transition happens. For us, that's a success for the reason being that we will potentially avoid readmission, or for that individual to just keep coming back to the hospitals or go to other hospitals, what we call sometimes is the hotel row. They go to one hospital and then the following week they'll go to another, just to get that a place to warm up or just eat or what have you. But that is a success for us, is to be able to have that ability to transition individuals. The other is from a hospital and also at the practice level is to screen individuals for housing insecurity and other insecurities, but since we're talking about housing, and to be able to find ways to refer the individuals who's having the housing insecurity, address those issues by us having a partner in the community that will help that individual address that insecurity. The other success is from an anchor perspective, where we have been in some of these communities for over 100 years. So we've seen the communities grow. We've seen the diversity and this appropriateness of equity. So our success is, for example, watching the project that we did with you, Steve, and San Marino. The transformation of a neighborhood that is located, only a few miles away from our hospital. The transformation of that neighborhood, not only based on housing and the environment, the outside environment, but also the economic activity that it gets rejuvenated around that project. So that is, for us, is a success story. But just to add another piece to this, one of the things that we've learned with the pandemic has been how the impact of not having the impact in healthcare by individuals not having appropriate housing. I think that we could have avoided the huge impact and hospitals, et cetera, by those individuals who didn't have appropriate housing. And these are the individuals the major responsibility is to keep the economy going. These are service workers. These are other parts of the economy keep going. So I think that housing is definitely a major.
Great, thank you, Pablo. John, how would you envision, just two thoughts. One, the more opportunity for increased local control or decision making, number one, and number two, more incentive for, I think I heard a statistic, and you guys can correct me if I'm wrong, but for each homeless person on the streets of LA has 3 to 5 social service workers assigned to them, with a lot of those agencies overlapping. So, you know, what would an incentive look like for all of these agencies to actually work together and think about the allocation of those resources?
Well, it's an excellent question. And we did have a waiver program here in Los Angeles known as Whole Person Care, which is winding up its 6th year. And that's where we saw the phenomenon you're talking about. Every agency had a hand in it, and we had care managers bumping into each other, and the result was care manager fatigue on the part of the beneficiary, who said, just stop calling me already. So I do think I'm a big fan of local control, because every community is a little different. The provider setup is different in LA than it is in Northern California. And I think if we had the ability to come together as local agencies and come up with a way to have a lead care manager that then called on the other services to deliver them in a holistic and integrated way. That's the biggest issue, going back to what was said earlier by Scott, is that the silos are all the way embedded at the local level, because agencies do not have the ability to cross-subsidize each other. So we would advocate for someone, and I'll raise my hand and say we'd be happy to do it at the managed care plan level, is be the coordinator of that and the integrator. But it would really require that the lead agencies behind them, cascading from the federal level to the state and the local level, have that ability to integrate their activities together. And that's been a huge problem. And I also want to go back to Tony's point. I haven't read that book, but I've always characterized what he described the following way. You have a very sharp curve aside a cliff, and lots of cars fly off the cliff. So then you wind up sending ambulances to pick up the damage at the bottom. So we have a choice. We can either build a guardrail at the top, or we can send more ambulances to the bottom. And in our fractured, siloed system, we're investing in way too many ambulances and not enough guardrails. I also agree with Tony. The combined spend on social services and healthcare in the United States compared to our peer group of nations is about equal, but the distribution is exactly as he described. Way more on healthcare, not enough on social services.
Yeah, that's a great visual image that hopefully we can all kind of carry around with us. Betsy, so one of the things that we've done is, during the, with the vaccine, I think we've opened up numerous of our senior properties, especially for vaccine. And we've been successful in hitting 100% of our residents getting vaccinated when we bring it to them, because we're hosting it and there's that trust factor that you indicated. Are there any models that come to mind that you can kind of put out there as here's a place or a program that's done it well using the housing platform for the delivery of these other services?
That's an excellent question. We have seen what I would call, and I don't mean this disrespectfully, one-offs where just one, like United Healthcare working with a housing provider in one building or one city. But I've not seen anything scaled, sort of replicated and then scaled across the country that would help everybody in affordable housing. And there's also a real difference between an affordable houser like National Core and a local housing authority that just has less resources, may have less staff on site, may not be able to provide the level of service that you do. So even as much as we're talking about the healthcare system being somewhat fragmented, I think the affordable housing system also is. And, sort of to John's point, it's having one person be the integrator, I truly think is the way to go. But back to something you said earlier, Steve, it's not necessarily that other entities don't have the time to do things like a SNAP application or help someone get back on Medicaid. It's that those things are complicated. I'm a lawyer and I have to go help people try to access food. And just let that sit for 1 minute. You need, in many cases, a very experienced legal advocate to help you get back into your housing, access food, access healthcare. There's something really wrong with that. And the system itself is incredibly complicated. If we had one universal application to apply for all these benefits, that would be an enormous step in the right direction. But it couldn't. Yes, I see John's thumbs. But just to let you know, many of the programs have different income and asset requirements state by state. So there's no uniformity. So if you're an entity like Pablo's that stretches across a bunch of states, who's going to learn all that? Who's going to hold that and be able to bring that to your patients, to the people who come to your facilities? It's just incredibly complicated. It would be great to scale the whole thing back and just start fresh. Like, are you poor? Do you need food? Here you go.
Yeah. I just listened to this last week's Freakonomics podcast about why is it good social programs don't get scaled up the way we think they should, or the way that they academically. So I'd encourage all of you to go, I think the most recent Freakonomics, and kind of hear what some of those barriers are. I'm going to answer the question about where affordable housing gets built. Many of you in DC will understand affirmatively furthering fair housing. And this is a lot of it was based on a Dr. Raz Chetty study about, kids that go to good schools, have a significantly better series of outcomes. There's been a significant movement about moving the development of affordable housing into what they call opportunity communities that have better services all the way around. The challenge is when you're taking investment dollars out of the more challenged neighborhoods and putting in the more affluent neighborhoods, you're reducing the opportunity for revitalization in the challenged neighborhoods, and your dollars don't go as far in the opportunity neighborhoods where land is much more expensive. And so without more money into the system, to just divide the money that we have now is actually resulting in fewer affordable housing units being developed and fewer challenged neighborhoods being revitalized. So it's something to be very thoughtful about balancing. I also wanted to mention the largest federal housing agency is the Treasury Department, because Treasury controls the tax credits and, more importantly, CRA, the Community Reinvestment Act. And if the Community Reinvestment Act were to give direction about what priority investments or linkages or what community development actually looks like, that can move significant private sector resources to be investing in a lot of the things that we're talking about today. So there's another opportunity along those lines. So we have 5 minutes left. I'm going to ask each one of our panelists to take 1 minute to what is the one thought, and Scott, I'm going to start with you so that you get ready. What is the one thought you would like to leave with our audience today as an actionable next step for them to take away and think about? Scott.
Thanks. So am I muted or am I okay?
You're good. And now you have 40 seconds.
Oh, I blew it. I think we're on the verge of a real paradigm shift in terms of affordable housing thinking at this point. I mean, 25 years ago, we shifted the focus of our homeless McKinney-Vento programs towards housing first, which was an integrated way to say we have a site-based housing where you can help people with their problems. And I think that needs to be taken across the aisle to deal with tax credit properties and Section 8 and public, the whole range, and have a more integrated approach to helping people. And anyone, I ask people to go look at some of the things that National Corps is doing over the last year with COVID. Really their enriched services have been a lifeline to the residents in those. And I think we need to look at that more holistically in terms of our affordable housing programs.
Thank you, Scott. Tony.
Well, I would say, consistent with the number of the panelists' point, this whole idea of incentives. We need to create much stronger incentives for healthcare, quite frankly, to lean into community. And, part of that is about coordination, as was described, having some sort of central coordination function for many of the social services. But there's also a kind of an inadequate incentive structure in the healthcare delivery system to essentially get out of the walls of the healthcare delivery system in the way that John and Pablo and other leaders have done because of their own recognition of the futility of our current paradigm. We need to structure much stronger incentives so that more of the actors in the healthcare space are looking like Pablo and John and some others, and leaning into community prevention and essentially creating this sort of virtuous cycle of investments in prevention that lead to more of a configuration that looks like what Bradley and Taylor described in the American Healthcare Paradox as the formula for a healthy society.
Thank you, Tony. John.
Integration of healthcare and housing for those people who are homeless. And that starts at the financing level and at the programming level. And apparently, listening to Scott, it needs to start at reorganizing the authorization progress system in Congress so that they're thinking in an integrated fashion as they're devising budgets, policies, and legislation that effectively direct the people we're serving.
Thank you, John. Pablo.
So outside of incentives, I think it would be important to bring together not only healthcare, but the rest of the economic engine, both business, businesses, et cetera, to work on how to make communities more resilient and more sustainable. Because every time we either have an economic crisis and now we have these, the pandemic, it's these communities who are not resilient and sustainable are the ones that are being impacted the most. And we're seeing the impact on the overall economy. So everybody is hurt by it. So.
Yeah, great point. Thank you. Betsy.
Yes, I would say at the beginning of COVID, agencies like CMS, which usually move at glacial paces, did big, bold things, telehealth being one of them. So for lots of people, being able to keep in contact with your medical professionals over the last year has been crucially important. We're able to do that. In this country, if we wanted to address the issue of homelessness and lack of affordable housing, we could do that. And I think that's what I'd like people to leave with, especially people in DC in positions of power who could actually move levers on the federal level. And I do think this is, we've had a moment over the last year, we're still in it. And this is a moment to do something big and bold.
Yeah, I think that's a great point. Things happened in weeks that people said could never happen. And so I think that should give people empower people to think in those terms as we go forward. So first and foremost, thank you to this panel. Appreciate you all very much. This is recorded and it'll be available if any of you want other people to watch it and see if there's value in it. And thank you to our audience. Thank you for taking time to listen and learn today. With that, everybody, please stay safe. Have a great day. Appreciate all of you. Take care.